Thank you so much for the introduction. I'm really pleased to be here, and there's so many of you in the audience that I've come across both through my student years and in my professional career as well, so it's really nice to see some familiar faces out in the audience. And I really hope that I can kind of give you a slight slither as to what it's like as a clinician on the ground, and I hope it's not too clinical, and I hope it's not really boring. If you're getting bored, just let me know and I'll move on. And I can gas bag about something else. As the previous speakers have done, I would also like to acknowledge that we are on Yorta Yorta land and extend my respect to elders past, present and emerging, and of course extend that respect to any First Nations people in the audience with us today and anyone who might be listening in to the recording of this conference. I have quite a connection with Shepparton. I was here as a medical student 10 years ago and I found it a really important place for me in my journey to where I have become and what I'm doing now as a clinician. I have a lot to thank Shepparton for, including a husband who happens to be in a couple of those posters there with me, and I really fostered a sense of community here, and that has really driven me on my health advocacy journey, and through my time here as a medical student getting involved in the Outlook Rural Health Club, it's helped me really establish those roots and continue to find that passion and drive to continue in what I'm doing today. So thank you to the Shepparton Theatre Arts Group for my husband, who is also a doctor, and it's really great to be back here and to see how things have changed over the last little while. Why me? Like, why am I talking to you? Who is this rando? So, as the bio did say, I work quite heavily in the sexual health space. I'm a rural GP obstetrician, pretty much pick a town in central Victoria and I probably work there. I'm lucky enough to live on the lands of the Dja Dja Wurrung people in Bendigo, and I do some of my work there, but I still provide care to people living on Yorta Yorta country and Tangarang country as well. So I get around depending on the day of the week and the week of the month and provide the whole spectrum of pregnancy care. The good, the bad and the maybe not quite so good as well. Provide general practice services including small rural hospital-based services as well, and up until recently was doing urgent care work in the small ED of the Castlemaine Hospital. HIV medicine and gender affirming care are my new real passions, and I really developed these as a final year medical student where I had the opportunity to be able to work with some amazing clinicians in Melbourne and surrounds, and I realised that there was a really large gap in what we were able to offer people living in rural and regional Victoria. So probably sillily semi-taken that upon myself to try to provide some of these services, and I'm really hoping that with this presentation I can bring you all along for the ride so that I can encourage any of the clinicians in the room today that if you were toying with the idea of doing HIV medicine or dabbling your toe in gender affirming care, that's something that you can do, and it's not hard medicine. Like, I'm not super clever. You just have to be really interested and really passionate. And so I hope that I can drag some of you along with me on the journey. I'll try not to be too clinical, and as I said, if I get really boring, just tell me to shush and I'll move on. Obstetrics obviously is something that's really important, and we know with the number of rural birthing units that are at risk of closing around the country that it's something that we really need to continue to support. I wanted to give a couple of updates in case people weren't aware of what's been happening in the space in the last 12 months or so. So for the non-clinical people in the room, SSRIs are serotonin selective reuptake inhibitors. They are a form of antidepressant and anti-anxiety medication. We do know that you have significantly better maternal and fetal outcomes if maternal mental health is well managed in the antenatal and peripartum and postnatal period. So by no means am I suggesting that those of us out there who are prescribing don't keep prescribing SSRIs for your pregnant people, because we know that mental health and good mental health is really important for good outcomes. But one thing that I wanted to make people aware of in case they weren't is that there's been increasing evidence in the last 12 months or so, and this was a study that was published in the British Medical Journal in about mid last year, that the use of these medications that we've so lovingly used for many, many years can actually be associated with delayed neonatal adaptation. And what I mean by that is, I'm going to get a bit medical, so apologies, a 5-minute APGAR score. So this is our way of determining how well a baby is when they're born. What is their colour? Are they moving around? What's their heart rate? What's their tone? What's their breathing? How grumpy can I make them when I rub them up? So this score is an APGAR score, and a 5-minute score of less than 5 has been associated with delayed adaptation. Similarly, if they've had any resuscitation at birth, or if they've had admission to a neonatal ICU after birth for respiratory support. As I said, I don't want you to stop prescribing because these are really important drugs, but I wonder from an equity point of view whether or not we need to be banging on the doors in Spring Street and suggesting, or possibly even up in Canberra as well, whether or not some of the other alternative options, which are safer in pregnancies such as agomelatine, need to be PBS listed. We know that postcode, unfortunately, can be associated with worse outcomes, and it shouldn't be. So what I would like all of you to do is have a think about what you're using, deprescribe where you can. This is dose dependent, but really thinking about how you as individual advocates can go to our policy makers and suggest for further equity for our patients in terms of access, in terms of cost. Again, around mid last year, RANZCOG, or the Royal and Australian New Zealand College for Obstetrician Gynecologists, released an update to their preeclampsia and preterm birth guideline, which has recommended, here we go, let's see if my IT is going to work, that all pregnant people should be screened for preterm preeclampsia risk in their first trimester. They had this nifty little tool, if it will load. Essentially, this is a tool that's quite voluminous in nature and has been shown to have significantly better outcomes than doing a history-based assessment for preeclampsia risk alone. It is utilising a number of different factors, which is all well and good if you've got access to ultrasound support, and all well and good if you've got access to pathology collection sites, and all well and good if you've got access to money. But I'm concerned, again, that we're going to see this dichotomy between what our metropolitan patients and the outcomes that they're able to have versus what our regional and rural patients are able to have is becoming starker. So a couple of the blood tests that used to be really very common, and when we were doing the old school first trimester screening, and a lot of our rural patients are still utilising this screening service in early pregnancy, gives you an assessment on the risk of chromosomal abnormalities such as Down syndrome. With that old school screening, a couple of these markers were actually in it, which is great. So one of them being, again, apologies, pregnancy-associated plasma protein A, or PAP-A, has a really strong likelihood and association with preeclampsia risk. Now, as we've seen everybody wanting to do gender reveals, we've moved towards this NIPT testing, or non-invasive prenatal testing, and we're not actually getting it. So now for us to then order extra tests to be able to do this screening, we're talking hundreds of dollars in addition to the $450 or so that these people are already paying. All well and good if you've got lots of money, but perhaps not so useful when you're living out in the rural areas, because often you need to go to a specialised pathology collection provider to be able to access this testing too. Another component of this thing, and I wish I could show you, but give you all the slides and you can have a look and have a play later, is that we want to ideally get an idea of what the blood flow through the uterine arteries that feed the uterus and feed that baby are doing, because there is evidence if that flow is slow or the flow is impaired, that also can be a very strong predictor for preeclampsia risk as well. But again, that requires training, and access to ultrasonography, particularly in our rural towns, is really challenging. So again, guidelines are great, but we also need to, again, be a chorus of people that realise that not everything that's available in the city is also available in the country. And where maybe we don't have access to all of those things to feel like that beautiful little tool, some is still better than none. Apologies, that was really clinical. I'm going to hopefully be a little bit more fun in a second, if this will let me click. Cool. So fertility medicine. We've seen some really amazing wins in this space in the last year or so. For those of you who weren't aware, we now have access to public fertility care in this state, which is amazing. It has been led out of the Royal Women's Hospital, and as you can see on the map where we've got the big blue stars, these are our regional hubs where you've got local providers who are offering fertility care. But everything is centralised from the referral pathway through the women's. This has been an absolute game changer for my gender diverse and trans clients, particularly if we're talking about the initiation of gender affirming hormone therapy, because often that is associated with the risk of infertility. So it's great to have a public service available locally to me where I'm working, where I can send my patients for expert advice and storage. Abortion care is something that I'm pretty into. What I've been noticing through the work that I've been doing through the Sexual and Reproductive Health Hub in Bendigo, at Bendigo Community Health Services, is that we're really hoping with the deregulation of MS2 step by the TGA that we would have fewer referrals, because why would we not? When more people can prescribe, it'll be so much better. People living out in the sticks won't have to travel all the way to see us or have to utilise telehealth care. But we're not really seeing that, which is really frustrating. So again, I don't have to convince you all because you're here in the audience and we're at a sexual health conference, but it's really important for us to continue to fight the fight and to be pushing from the beginning of medical education to be putting abortion into normal healthcare and for it to be seen as everyday regular care, so that we can start to break down those barriers. So instead of it being seen as something extra that you do, it's just what you do. The other thing that I've noted, and up until recently, because now I'm pretty obviously pregnant, was that I've been doing a regular surgical termination of pregnancy list in Kyneton. And I've noticed that whilst we've had some really big wins and some really big gains since the end of 2023, when that mandate for larger services to provide termination services was made, there's really just not enough access. I'm finding increasingly that the people coming to access the service with me in Kyneton are actually coming from the northern and western suburbs of Melbourne. I'm just going to give something really inconceivable for you, which to me blew my mind. I recently learned that when the government gave this directive, they gave health services 1 month to start a stop service, but said, oh, hey, by the way, we want you to do it within your current funding model. We're not going to give you any more money to do it, but we expect you to be able to do it in a month, and then we're going to ask you how many you've done next month. And great, it was really important to get some butts off seats and things happening, but it's really not feasible and it's really not sustainable. When you've got the western area of Melbourne, which is one of the biggest growth corridors in the state, with a huge population being serviced by 5 places at the Western and 6 places at Bacchus Flash Health every fortnight. That's obscene, and it's no wonder that I'm starting to see these people coming to me in Kyneton, where thankfully our local access is a little bit better. So again, all of you in the room, I really want you to be pushing and fighting, and we need to be advocating for increased funding for early surgical termination of pregnancy services, because at the moment access is just ridiculous. And as soon as you're out of Melbourne, yeah, good luck getting a stop after 13 weeks. And that's something, again, we need to be working on upskilling our regional providers so that they are confident and safe at providing those later gestation surgical terminations of pregnancy as well. Bread and butter general practice, so it should be. Really frustratingly, even though contraception is bread and butter general practice, within our Sexual and Reproductive Health Hub, we're still seeing a huge number of referrals for IUDs and implants. These are not hard procedures. Yes, they are associated with a small amount of risk, but we really, in this day and age, shouldn't be seeing that many referrals coming through. So if those of you out in the audience are interested and you're already doing so, be aware that there's a number of places that you can go to for training. If you're nearish to Melbourne and you're not an implant-on trained person, you can do the online modules, and then they do free practical training for implant insertion. Please do. Places like Sexual Health Victoria have their own IUD training course, and they also have IUD and Implant on Train the Trainer courses as well. I encourage you to go and check them out. And one thing, because again, I like to take on more than I can sometimes chew, is that within Bendigo Community Health Services, we've now started training some rural doctors and regional doctors, and I myself are leveraging my medical indemnity to be able to train other doctors to insert IUDs so that they can go back to their communities. And so far, successfully, we've trained 4 rural and regional doctors who have now gone out and are providing services in their communities. SDIs are going up because people are having sexy times, which is great. Again, most of you already know all this, and I apologize if I'm boring you, but in case you've been living under a rock, some of our guidelines have changed. The Australian SDI Management Guidelines for Use in Primary Care are updated regularly and are an amazing resource. And azithromycin is no longer our first choice for chlamydia. Please be aware. Syphilis rates have been quite concerning. I know there's a number of public health people in the audience, and I'm sure that's something that you're all very worried about. And because of the numbers of congenital syphilis that we have been seeing, we're now seeing increased pregnancy screening as well. So it used to be that we'd just screen in very early pregnancy in the antenatal period prior to referral on to obstetric services, but we're now also seeing increased screening at around 28 weeks and then again at 36 weeks. And this is now something it's a big change for those of us working in the obstetric space. And in the little office that I share with a couple of colleagues in Echuca, we've got sticky notes to remind us because it's still relatively new. It's only been since February that that's changed. For those of you who have a decent amount of interaction with the MSM or men who have sex with men or bisexual men who have sex with men community, DoxyPEP might be something, if they're not already asking you about, they will be soon. There have been some Australian consensus guidelines published relatively recently about DoxyPEP. The main recommendation is that it should be used for syphilis risk reduction, with some added benefits for chlamydia. But really, if you're thinking about gonorrhea, don't, given all of the multi-resistances that we're already concerned about. But something to be aware of, it's an up-and-coming space, and more patients are going to be asking you about it. So having the ability to have a sit-down conversation and assessing risk for these people is really important. And the other thing is, even if you're outside of the city, don't forget about Mpox. It's out there, numbers are going up. And for those of us that only have a small patient cohort that this might be applicable to, it's really easy to forget, but I don't want you to. Menopause. Finally getting the time of day that it deserves, because how much of the population can be affected? Oh, a lot. Some cool changes that have happened thanks to the Senate inquiry, which really got government realising that about half the population is affected. So maybe, and they can vote now. So maybe we should do something about that. So we've seen some really positive steps in this space. The PBS changes at the beginning of March have been an absolute game changer for a number of my patients, because having really effective, good quality medicines not available on the PBS is completely prohibitive for a large population of the people that I care for. So this has been so good. We're particularly pleased about this given the ongoing patch shortages that we're seeing, which is of significant concern for a number of patients, because you just get them nice and stable and then all of a sudden, sorry, no Climera for you, it's been discontinued. Oh no, you want to use something else? Oh sorry, you can't, we just can't get it. And we know that the supply issues and supply chain for rural and regional areas is significantly worse than the city, and you just don't have the option of multiple pharmacies to be able to utilise. So something to be really aware of, and particularly in terms of equity of access and equity of care for things that we need to continue to push. A bit of a shout out to the Australasian Menopause Society. If you haven't heard of it, you should. They have an amazing amount of resources for patients, for clinicians, for researchers, and they're always up to date in terms of what's happening in the space. So I really do encourage you all to check out their website. They've got some really great resources for you to have a look at. How cute is my AI HIV? I've learned how to do AI generative pictures recently, and it's just so cute. If you're not a HIV prescriber, again, this is not hard medicine. It's very easy. If I can do it, anybody can do it. So, and as you can see looking at this map here, so I pulled this directly from the ASHM website. They have a find a prescriber, and you can find one for hepatitis B and you can find one for HIV. And you can see here that pretty good access in Melbourne. Pretty good, yeah. The little number 2 up there, that's me and my colleague Harris, who's just got his training set up in our sexual health hub, and our public hospital ID service, the nurse practitioner there as well. So really we've got a public hospital and then the two of us. And then there's a couple of other dots around, but as you can see, it's pretty scarce. Yes, the absolute HIV numbers in the community are pretty low, but this is life-saving care and really important from a public health perspective to help limit the burden that we have on our hospital system as we're seeing more people getting HIV and ageing. So if you're interested, become a S100 prescriber. I know that in the most recent ASHM newsletter, I think came out last week, they have got expressions of interest. Click it, do it, it's free. The free course, one of the few free courses that you can do. It's online. I had the benefit of doing the old face-to-face and then the online, and the online's pretty much just as good, except you don't get good food. And it's run over about 4 weeks. So please do consider it. If this is something that you're mildly interested in, we need more and more people being able to provide these services outside of Metro Melbourne so patients don't have to travel. Again, we need to destigmatise so that we can improve access and care. And finally, my new kind of pet project that I've been increasing my skill set over the last probably 4 or 5 years is gender affirming care. It started with a couple of patients in my private general practice work who I wanted to be able to support on their journeys. And then now, amazingly, we soft launched our trans and gender diverse clinic through Bendigo Community Health Services Sexual Health and Hub in April. And we're seeing huge amounts of people coming through. So the World Health Organization estimates that about 0.5% of the global population identifies transgender or gender diverse. But interestingly, in a 2018 National Sexual Health Survey that was done for year 10 to 12 students, 2.3% of students identified within that cohort. So we're not talking tiny numbers here, we're talking decent numbers of people who need life-saving care. Again, it's not hard medicine, it's really bloody easy to be honest, and all it requires is a positive outlook and just to not be an asshole, really. I've got patients travelling to see me from a really long way away. I've got patients coming from Shep. I've got patients coming from 1.5 to 2.5 hours away to come and see me in Bendigo. And whilst I do try to do some of the care remotely where possible, it would be so great if these patients didn't have to travel at all. So again, not hard medicine. If you're interested, please do it. ASHM's got a great course. Thorn Harbour Health have got a great course. Please do look into it. Unfortunately, not free, but relatively cost effective and tax deductible. So have a think about it, and please do, if it's something that you're interested in and you're needing a bit of support, add to those numbers. So you can see here, so the AusPath, if you haven't heard of them, they're the Australian Professional Association for Trans Health. They are fab. They've got lots of resources for clinicians and for patients as well. And there is a way of, you can be a paid member and you can put yourself on their list so that people who are looking to receive gender affirming care can Google you in a safe way. And I had a look the other day and there's literally only 7 primary care providers outside of all of Melbourne in Victoria. It's pretty bad. So help me change those stats. Let's get excited. Let's provide some really cool care and make sure that everybody feels safe and secure and can live their best lives in our communities. And I speak really fast, so we may, I don't know. I've actually got time for questions. So I guess I wanted to try to give you a little bit of an insight into what I'm seeing on the ground. Encourage you all to participate in other areas of sexual health medicine that maybe you're not already participating in. And just know that there are champions outside of Metro Melbourne and that we, by being here together, have a really amazing opportunity to be able to support each other and expand the services and improve sexual and reproductive health outside of Melbourne. Thank you.